The top 10 most common presentations that the advanced practice provider should be aware of when practicing in otolaryngology head and neck surgery. By Jose Mercado, physician assistant. Disclosure. I have no disclosures or conflicts of interest with this presented material to disclose. Hello, I'm Jose Mercado and I'll be your speaker. Let me tell you a little bit about myself. First learned medicine while serving as a medic in the U.S. Army. I went on to complete the PA program from Miami-Dade College, where I focused all of my training in ENT, and I completed my Master's of Medical Science degree from Nova Southeastern University. I am the president of the Society of PAs in ENT and the founding director of the ENT for the PAC workshops. Additionally, I am the founding program director for the NFO's PA internship program, as well as the director of PA education. The learning objectives for the top 10 ENT conditions are quite simple. We're basically going to identify and review the presentation of the top 10 potentially dangerous and common ENT conditions, and then discuss their workup and treatment. We will do this in a question-answer format. What I hope to do is to give you the key things you should look for in patient presentations and treatment options. We'll be focusing on distinguishing bacterial otitis externa from fungal otitis externa, treatment options for acute otitis media and chronic otitis media, what to do when you encounter an adult patient with unilateral otitis media, the things you should think about when you encounter sudden sensory neural hearing loss. We'll talk about the differential diagnosis for chronic cough, the treatment options for epistaxis, severe sore throat, vertigo, head and neck disease, and sinusitis. So, without further ado, let's delve into our first question. This is a 26-year-old male who presents for initial consultation regarding a chronic left ear infection for 3 weeks. He states he was initially treated with cortisporin otic suspension. He states the pain has resolved but is now clogged and itchy. Which of the following is the most appropriate therapy? So first, let's decide what the diagnosis is. This sounds like it was treated for acute otitis externa. The pain is gone, but now he's got clogged, itchy ears. Could he have wax? Could he have a fungus? Possible. So would Floxin otic drops or Ciprodex otic drops help? No. Dermotic, we use that. It's a steroid-based drop that we use to treat eczematoid otitis externa. What he needs is oral toilet with Lamisil powder, basically getting out all that fungal debris and drying up the ear. We'll review some basic anatomy. The helix and antihelix all form the outer ear. The external auditory canal is a conduit to the middle ear and it's lined with migratory skin. The tympanic membrane separates the middle ear, and the middle ear connects to the nasopharynx through the eustachian tube. The eustachian tube is responsible for equalizing pressure in the middle ear, preventing regurgitation, and facilitating drainage. So just remembering this image and what those different sites do will help you figure out what's going on with the ear. When we're looking at the ear, it's very important to be able to visualize your landmarks, making sure you can see the tympanic membrane. This is essentially a normal tympanic membrane. We've got some cerumen here, but it's not causing obstruction or hearing loss. And then, of course, cerumen comes in different consistencies, colors, flavors, etc. Here you have an example of an acute otitis externa. There's some redness, here's some exudate. This is more of an acute process. You compare that to the other side, you have increased debris. This has probably been there a little bit longer. Both of these cause swelling because the canal is bone lined. When there's swelling, that causes pain. You compare that to a fungal otitis externa and you see this cottony fluffy debris with the brown spores, and here we have black spores. Both of these are classic fungal otitis externa. Our second case is a 6-year-old female who presents after failing a school screening audiogram 2 months ago. She denies fever, pain, or otorrhea. She's allergic to penicillin. Mom denies any recent upper respiratory infection or recent ear infection. Her last episode, she says, was over 3 months ago that resolved spontaneously. Her social history is remarkable for her being involved in school and being exposed to secondhand smoke because her father smokes. They have 2 dogs, a cat, and 3 birds. So when you look at all this information, relevant things is she failed a screening 2 months ago. She's exposed to secondhand smoke and have pets in the home. All of these things suggest a chronic middle ear effusion. On physical examination, we see a tympanic membrane that's markedly retracted. We see yellow, dull middle ear effusion. Manual pneumatic otoscopy shows there's little to no movement, and tympanometry confirms a flat type B tympanogram. So this is a classic chronic otitis media with retracted tympanic membrane. So what is the most appropriate next step? Do you want to use topical nasal steroid sprays, nonsteroidal anti-inflammatories, macrolides, or would you consider surgical intervention? Based on the severity and longevity of her symptoms, she is a candidate for ventilation tube insertion. Keep in mind that in asymptomatic patients, there is no pathogen to treat, so oral antibiotics are not indicated. Again, the best case here probably would be to remove that fluid to restore hearing and break the cycle. So now let's look at some normal ears. This is a great example of a normal tympanic membrane. Nice and gray, translucent. You can see through it. It's not retracted. It's not bulging. You compare that to this bulging tympanic membrane. The area is red and angry and it's full of pus. Compare that to a serous otitis media. So here we have a normal tympanic membrane. And I like showing these because these are normal variants. What you have to do as a clinician is correlate this with the patient's history and physical findings. Compare that to the image on your right. You can see the clear bubbles in the ear and some amber fluid. If you're not sure if there's fluid or not, or if those bubbles represent tympanosclerosis, you can have the patient Valsalva. When they equalize the pressure in the ears, you can watch the bubbles move. You can also perform manual pneumatic otoscopy to see if the drum moves. Additionally, you can perform tympanometry, which will measure normal type A, a flat type B, or negative pressure type C tympanograms. If pain and inflammation are absent or if hearing is unaffected, antibiotic therapy is not necessary since it generally does not respond to continued antibiotics. Presently, there's no evidence that topical nasal steroid sprays or antihistamines has any effect on decreasing otitis media. Some would argue, however, that topical nasal steroid sprays may improve mucosal swelling and even eustachian tube function. But again, you're treating the eustachian tube dysfunction or underlying allergic component, not the middle ear effusion. Antimicrobials and oral corticosteroids do not have long-term efficacy and are not recommended treatment options. This next point that I'm about to make is very, very important because it transcends several disease processes. Using antihistamines during an acute infectious process, whether it be otitis media or sinusitis, should be avoided since the drug may prolong duration of symptoms. Again, keep in mind, antihistamines dry secretions. Do you really want to dry infected secretions? No. What are the guidelines from the American Academy of Otolaryngology? Well, they have the top 5 indications for ventilation tube insertion, and they include otitis media with effusion for 3 months or greater, a conductive hearing loss of 30 decibels or more with a patient with middle ear effusion, recurrent episodes of acute otitis media, that's 3 or more episodes in 6 months or 4 or more episodes in 12 months. Additionally, any patient with any kind of craniofacial anomalies such as Down syndrome or cleft lip, cleft palate that would predispose to middle ear dysfunction is a candidate for ventilation tube insertion sooner rather than later. Additionally, any patient with chronic retraction of the tympanic membrane or pars flaccida is at increased risk for the formation of cholesteatomas. In cases like that, it's more important to equalize the middle ear space with the insertion of ventilation tubes to prevent a cholesteatoma formation. How do we do a laryngotomy with ventilation tube insertion? We make an incision in the inferior anterior quadrant. If there's any fluid, we take it out. After we take out the fluid, we insert a pressure equalization tube. These tubes could last anywhere from a few months to a few years. Older patients that can tolerate this have this done in the office. Patients who cannot tolerate or children are done as outpatient under anesthesia. Another important thing to keep in mind is once those tubes are in, they do not prevent the recurrence of middle ear disease. Otorrhea is common in 21 to 34% of patients with ventilation tubes. That being said, now you have direct access to the site of the infection. This is where autotopical drops come into play. A 3 to 5 drop dose of topical antibiotics deliver a total of approximately 1 to 1.5 milligrams of medication to the middle ear. But the concentration of that medication is over 3,000 micrograms per milliliter. This concentration exceeds the minimum inhibitory concentration necessary to eradicate any known relevant pathogens. When you compare that to the properties of penicillin-based antibiotics, such as amoxicillin at 90 to 100 milligrams per kilogram per day, that only delivers a concentration of only about 8 to 10 micrograms. Well, what about Rocephin or ceftriaxone? That delivers only 25 to 30 micrograms. So again, if there's otorrhea, autotopical drops, specifically fluoroquinolones, which is ofloxacin and ciprofloxacin, are the treatment of choice. Our next case is a 63-year-old Asian female who presents for consultation of hearing loss of the left ear after an upper respiratory infection 9 weeks ago. She completed a course of amoxicillin and is starting to feel better, but just can't hear. On physical exam, you notice a left serous otitis media. So what's the most appropriate next step? The key here is that we have an adult with unilateral otitis media. This should set off alarms in the back of your head and make you think of a possible nasopharyngeal mass. How do we evaluate that? With a nasal endoscopy. Otitis media in adults, again, should raise suspicion of a nasopharyngeal mass blocking the eustachian tube, which can cause unilateral otitis media. The rate of incidence is about 1.5 per 100,000 patients and is more common in Asians and Alaskans. The image on the top shows us a normal torus tuberous, which is the opening of the eustachian tube. The image on the bottom is that patient I just described. Our next case is a 60-year-old female who presents with a 1-week history of left-sided hearing loss with tinnitus. She had mild vertigo and went to the emergency department where she was treated with IV hydration, meclizine, and oral steroids. A CT scan of the brain was negative for acute intracranial pathology. The key to this question is that the patient was treated with steroids and has a negative CT scan. Most important thing is to quantify that hearing loss. Is this a true sudden sensorineural hearing loss, or is there something else going on? So we got an audiogram. Audiogram on the right, normal hearing is 25 decibels and above, shows normal hearing. Left ear, normal range. She has lost all the hearing in that ear. She has a left sudden sensorineural hearing loss. Non-idiopathic causes of sudden sensorineural hearing loss should be identified and addressed during the course of management. The most pressing of these are vestibular schwannomas or acoustic neuromas. We also have to rule out any cerebrovascular accident or malignancy. Up to 90% of sudden sensorineural hearing loss is idiopathic, and at presentation, it is presumptively attributed to things like vascular, viral, or multiple etiologies. 32 to 65% of these cases may resolve spontaneously. The key is to start appropriate treatment as quickly as possible. The Academy has guidelines. They recommend ideally within the first 14 days, but sometimes as late as 6 weeks, beginning a high-dose oral prednisone of 60 milligrams per day 60 milligrams per day for 7 days titrated. In the event that they cannot tolerate oral prednisone due to diabetes or other comorbid factors, we can consider intratympanic injections with dexamethasone, and it's 3 to 4 intratympanic injections repeated every 3 to 5 days. Additionally, you want to do serial audiograms to evaluate progression of hearing loss or improvement. And we also have to rule out any retrocochlear pathology. The key here is identifying these patients, beginning the steroids early, and ruling out retrocochlear pathology. Which of the following is the most common cause of chronic cough in an adult? All of these treatment choices can cause cough, but they're asking which is the most common. The most common is postnasal drip. Croup can cause cough, but is more common in children. Laryngotracheitis, or croup, is an inflammation of the subglottic larynx or upper airway, and more common in young children 3 months to 5 years of age. This occurs in the winter months and is caused by parainfluenza. Best way to remember this is think of my paracrouper. Parainfluenza causes croup. These patients will be worse at night and they'll have a barking cough. If you want to confirm this, you can get a lateral soft tissue x-ray, which will confirm a steeple sign. These patients are usually treated with cool mist, epinephrine, and oxygen. This is a nice little table that breaks down the signs and symptoms of the most common cause of cough. Second most common cause is reactive airway. This should be quantified with a pulmonary functions test. Acid reflux is the third most common cause of cough, and that can be treated with dietary modifications and proton pump inhibitors. Cough in 30 to 60% of the patients has been caused by sinusitis, and of course imaging, antibiotics, sinus rinse, and dealing with the mucociliary function and the root of the cause. I have to always say, consider a chest x-ray in any adult who has a cough more than 6 to 8 weeks. Our next case is a 73-year-old male who presents with recurrent intermittent nosebleeds that are worse in the morning, denies any antecedent trauma or recent upper respiratory infection. He is compliant with his insulin and his Plavix. Which of the following is the most appropriate treatment options? Obviously, we're not going to get him to stop the Plavix. He's taking it for a more serious condition. We're going to start with the least invasive, highest diagnostic yield, which is usually chemical cauterization. So let's talk about how bleeding to stop. Why? Because most bleeds occur in the anterior aspect of the nose through Kissebuk's plexus, also known as Little's area. Occasionally, the posterior nasal cavity can bleed, such as Woodruff's plexus. When you encounter severe bleeding, that's probably a sphenopalatine artery bleed. Posteriors tends to be more difficult to control and may suggest an underlying etiology, either severe hypertension or even neoplasm. What are some causes for anterior nosebleeds? Usually is trauma, either nose picking, blowing, previous surgery, irritants, topical nasal steroid sprays, foreign bodies, and even neoplasms. Systemic causes would include hypertension, poorly controlled hypertensives, coagulation medication, hereditary hemorrhagic telangiectasia, and occasionally some bleeding disorders. When you're applying pressure, don't put pressure on the bridge of the nose. Don't put the head back. That just makes the clots form in the back of the throat, and then they spit up blood. Now they have hemoptysis. The best way to do that is to put pressure on the anterior nose and keep the head in a neutral position. You want to spray or apply topical anesthetic with decongestant. I do this bilaterally. And then you apply pressure for another 10 minutes. After doing this, you can often visualize the offending vessel much better. Controlling of the anterior epistaxis is achieved using silver nitrate in circular formation from the outside, working your way in towards the center. You want to avoid the temptation to just touch that vessel, as that may cause further bleeding. I have to caution you about bowelite or cauterization, as that may result in septal perforation. Also, let your patients know that the silver nitrate can ooze onto the skin and temporarily stain the skin. You want to lubricate the nose with Vaseline or Neosporin and avoid any sneezing, forceful nose blowing, picking, etc. I generally follow up in 2 weeks, as recauterization is sometimes necessary. Other things that you can do is, if bleeding persists, is to pack the nose. You can use Vaseline gauze, gel foam, nasal tampons. or fibrillar. When packing with Vaseline gauze, basically you want to tightly squeeze in the Vaseline gauze so it adds pressure and stops the bleeding. When using nasal tampons, do not allow the packing to moisten until it's in position, as this will force it to expand. One of the downsides of these marrow seals or nasal packings is when you remove them, they may sometimes cause some rebleeding. When you're inserting these, make sure that you insert them horizontally along the floor of the nares. Do not force up towards the eyes or cephalically. And again, do not moisten until they are in place. I prefer the Rapid Rhino, which is easy to insert and remove due to its self-lubricating hydrocolloid fabric and ultra-low profile. This quickly confirms the nasal anatomy and provides gentle and even compression to all areas that may be bleeding. How do we use this? We activate it by soaking it in sterile saline for 30 seconds. Again, we insert horizontally and we inflate the balloons with air. We wait a few minutes to make sure that no additional congestion has resulted, allowing for rebleeding, as we may have to reinflate. The image to your left is a patient that was improperly packed. You can see from the bleeding, it's mostly anterior. The image on the right is a patient that required bilateral nasal packing to apply pressure to the contralateral side after we controlled his blood pressure and gave a blood transfusion. So controlling posterior epistaxis, you want to control any hypertension, identify any coagulopathy, and you want to treat that with fresh frozen plasma or even transfusions. So a type and cross would be beneficial, as well as checking for PT, PTT, and INR. Nowadays, we're having less and less Coumadin toxicity. This would be reversed with the use of vitamin K. One of the best ways to control the posterior epistaxis is with a posterior packing. In the event that the posterior packing doesn't work, you may consider endoscopic cauterization, either at the bedside or in the operating room under anesthesia. In the event the patient is unable to tolerate anesthesia for whatever reason, you may consider an interventional radiology consultation for arterial embolization. If you find yourself in a situation where you don't have a posterior pack, you can make a bolster pack using a Foley. The Foley is inserted in the nose and then taken out through the mouth. A bolster is tied and then the bolster is secured in the back of the nasal pharynx. Again, I prefer the Rapid Rhino. They have a posterior pack that has a balloon in the posterior and anterior, which gives you adequate pressure to the site of the bleed. Once it's in place, you want to wait another 15 minutes to make sure that there was no residual decongestion requiring you to add additional air. Once the balloon is in place and secure, I recommend the use of oral antibiotics, although there has been some debate lately regarding the need for prophylactic antibiotics to prevent toxic shock syndrome. The packing should remain in place for at least 24 to 72 hours. I seldomly, if ever, remove a nasal pack in less than 72 hours. This is an image of endoscopic cauterization. On your left, on your right is embolization accomplished through interventional radiation to control the epistaxis. Changing gears now, we have a 29-year-old female who presents with a 9-day history of worsening sore throat. She states the amoxicillin she took from urgent care did not help. The most appropriate next step would be, so what's going through our minds now? We've got a 29-year-old female with severe sore throat not responding to antibiotics. She's probably suffering from a peritonsillar abscess. How do we quantify that or confirm that? With a CT scan of the neck with contrast. History, they're going to complain of severe odynophagia, pain with swallowing. They're also going to have dysphagia, difficulty swallowing. They may or may not have fever. They may or may not have unilateral edema. If there's enough pus in the tonsillar fossa, they may have what's called a hot potato voice. A hot potato voice happens when they can't open the mouth because it hurts so much. You may also notice an elevated white count on CBC, and then of course the CT scan will confirm the abscess formation. So this is the physical image of that patient I just described to you. I had a strong clinical suspicion, so I had a CT scan, which confirms the abscess formation. Curette. Management options. We can either drain it with a needle, aspiration, or we can do a formal incision and drainage. Occasionally we find ourselves removing the entire tonsil. That's called a quinsy tonsillectomy. The choice depends on the site and location of the abscess. Smaller, deep abscesses are sometimes easier to reach with a large bore needle. Some literature suggests that abscesses less than 1 centimeter in diameter do not require drainage but will respond to conservative therapy. Keep in mind that both have similar success rates. Needle aspiration has a 90-95% success rate versus incision and drainage, which has a 90 to 100% success rate. The big thing to keep in mind when draining these abscesses is its close proximity to the carotid and the jugular. This is an image of a more obvious peritonsillar abscess. You see the fullness. The image above shows the 3 main sites that I would normally target when performing needle aspiration. Here you have the pus being aspirated from a tonsillar fossa. After aspirating any fluid from the abscess, you want to go ahead and make an incision with your 15 or 11 blade, and then using a curved hemostat, perform blunt dissection to open up any pockets and remove any residual pus that may be in there. These patients can then be sent home on oral antibiotics, penicillin based unless they're allergic, with a oral prednisone, and follow up in 2 weeks. They're also candidates for a possible tonsillectomy. Our next case is a 43-year-old flight attendant who complains of nausea and vomiting associated with severe dizziness. When she rolls out of bed in the morning, she claims to have had these symptoms for the last couple of days. She further states she had been previously healthy except for a recent upper respiratory infection 2 weeks ago. Her audiogram reveals a mild mid-frequency hearing loss. The most likely diagnosis is, so when we talk about dizziness, Meniere's is a diagnosis of exclusion. It's the last thing you ever want to blame. Benign paroxysmal positional vertigo is reproducible with the Dix-Hallpike maneuver. And those are all different from vertebral basilar insufficiency, which is essentially a circulatory problem. What this question is representing is dizziness with hearing loss, which is a classic trademark of labyrinthitis. So let's talk about that. Balance is not a single organ process. It is a multi-organ process that involves the brain coordinating signals from the ear, from the eye, circulation, touch, all of these impulses being processed in the brain. If even one of these is off, it can cause dizziness. When evaluating vertiginous patients, I break it down into a central versus a peripheral, keeping in mind there could also be systemic causes. So what are some central causes? Any circulatory or neurologic processes, to include multiple sclerosis, orthostatic hypotension, could be giving you symptoms of dizziness. In ENT, we focus on the peripheral causes such as labyrinthitis, neuronitis, positional vertigo, paralymphatic fistulas, Meniere's, autoimmunes, and ataxias. Systemic causes would include medication, endocrine, a migraine etiology, or disequilibrium, although migraine could be categorized under central. So if it's central, they need to see a neurologist or a cardiologist. If it's peripheral, that's ENT, keeping in mind medications. Simple algorithm that I usually follow is history. How long have you had it? Is this a new process or an old process? On physical exam, are cranial nerves 2 through 12 grossly intact? Is Romberg positive or negative? Can you reproduce the symptoms with a Dix-Hallpike? If it's central, then what I would do is consider imaging to include an MRI versus an MRA. and some labs. If it's peripheral, a simple hearing test, checking for symmetry. Obviously, if there's an asymmetric hearing loss, the possibility of retrocochlear pathology to include acoustic neuroma is exponentially increased. Other tests that I can do would include an ENG or a VNG to, again, better quantify where the problems are coming from. So the goal here is to differentiate essential from a peripheral cause. Neuronitis, whether it's cochlear or vestibular, will give you dizziness without affecting hearing, whereas labyrinthitis will cause dizziness with hearing loss. Central causes, again, vascular disorders, vertebral insufficiency, all these. When performing your exam, make sure you take a detailed history and you have a routine approach for your dizzy patients. Have patients describe their symptoms without using the word dizziness. Check all medication. With so many etiologies, the goal is to differentiate essential from a peripheral source. A 69-year-old male has noted a right neck mass while shaving 6 weeks ago. He denies fever, pain, dysphagia, or odynophagia. He completed a course of azithromycin without improvement. The next appropriate step would be additional 10-day course of antibiotics, a CT scan of the neck with contrast, an ultrasound of the neck, or a fonial aspiration. The key here is we cannot continue to do the same thing over and over and expect a different outcome. If the first course of antibiotics haven't improved symptoms, then it may not be an infectious process. We should start to think about a neoplastic process. So the most appropriate next step would be imaging to determine the size and consistency of this mass. An ultrasound of the neck will only tell us if it's a cystic or a solid mass, but it would not really tell us if it's malignant or not. Of course, a fonial aspiration would be a definitive histopathologic diagnosis. So this is where we get to use the guidelines from the Academy once again. Neck masses are common in adults, but often the underlying etiology is not easily identifiable. Malignant neoplasms far exceed any other etiology of adult neck masses. Importantly, an asymptomatic neck mass may be the initial or only clinically apparent manifestation of head and neck cancer. Timely diagnosis of neck masses due to metastatic disease is paramount because delayed diagnosis directly affects tumor stage and worsens prognosis. What are the common symptoms in patients with a neck mass? The mass lasts longer than 2 to 3 weeks. The mass gets larger. Masses that get smaller but don't completely go away should still raise your suspicion. Anything that affects the voice, pain or trouble swallowing, neck or throat pain, unexplained weight loss, or metastatic disease to the cervical lymph nodes is the most common type of cancer, with 85% of these arising from an upper aerodigestive tract primary. 10% of these are from an infraclavicular tumor, and 5% of these are unknown primaries. A good way to remember this is think that any swelling or neoplasm for less than 7 days is probably an inflammatory process. Greater than 7 years is probably congenital and benign. It's everything else that lasts between weeks and months that's suspicious for neoplasm. When examining the mouth, make sure to evaluate the lateral borders of the tongue, where cancer likes to hide, and pay special attention to the base of tongue. A good thing to remember is CITINS. CITIN stands for congenital, infectious, trauma, toxic, endocrine, neoplastic, systemic, or autoimmune. I prefer to use the differential diagnosis model, neoplastic, inflammatory, or mechanical, when trying to determine the differential diagnosis of these masses. This is a nice little table that I made that breaks it down from congenital, infectious, endocrine, neoplasm, or autoimmune. Head and neck neoplasms are like real estate. Location, location, location. Just based on the location, you already have a good idea of the usual suspects. Lateral neck swelling is usually a brachial cleft cyst, cervical lymphadenitis, cellulitis. Midline neck mass, most common, is a thyroglossal duct cyst or a thyroid neoplasm. Submandibular could be infectious. such as sialoadenitis with sialolithiasis or even Ludwig's angina. Supraclavicular, especially on the left side, would be Virchow's node, and of course the parotid. Examination can be performed by zones, and this is important when it comes to distinguishing on CT scan findings. Our last question is a 34-year-old female presents for consultation of recurrent headache. She states light and sound bother her. Her headaches were so persistent she went to the emergency department where a CT scan of the brain suggested quote-unquote sinusitis. The most appropriate next step would be A, amoxicillin, B, neurology consult, C, Levaquin, or D, nasal endoscopy. We're fortunate that in ENT with direct visualization we can see what's going on. Keep in mind that sinusitis is a diagnosis made by history and physical, not diagnostic tests. The differential diagnosis depends on location and duration of symptoms. In the previous case, the key was light bothered her, so it was suggestive of migraines. Flexible endoscopy would show if there's any purulent secretions. A CT scan of the sinuses is the gold standard, and we only culture after empiric therapy fails. So in summary, when distinguishing bacterial otitis externa from fungal otitis externa, bacterial has pain, whereas fungal has itching. Acute otitis media, there's pain, where with chronic otitis media, there tends to be just hearing loss. Anytime you have a patient with unilateral otitis media, especially an adult, check the nasopharynx to make sure there's no cancer. Any patient with sudden sensorineural hearing loss deserves an audiogram and steroids as soon as possible. The most common cause for a cough in an adult is postnasal drip, but don't forget possibility of a cancer. So get a chest x-ray after 6 to 8 weeks. With epistaxis, it's important to distinguish an anterior from a posterior epistaxis. Patients with severe sore throat that don't respond to conservative therapy, you should be thinking possible peritonsils or abscess. With vertigo patients, distinguish or differentiate essential from a peripheral etiology will help you direct management. When it comes to head and neck disease, distinguish an infectious process from a neoplastic process based on duration and severity of symptoms. And finally, with sinusitis, this is a diagnosis made by history and physical, not imaging. Thank you for your attention. Here is my email and contact information. Feel free to send me a message with questions or comments. Thank you.
Hello and welcome to the FCOM 2021 virtual presentation, The Ear, Anatomy, Physiology, Evaluation, and Treatment of Common Ear Disorders. I'm Mark Wydick. I'm a practicing otologist in Boca Raton, Florida, where I've had the pleasure of residing and practicing since 1994. Briefly summarizing my training, I grew up in Florida. I consider myself a Floridian, went to a Florida high school in Cocoa Beach, and then went to a variety of colleges in the Southeast, including Davidson, Florida State, Florida, and finally Vanderbilt, where I did my otology and otolaryngology training, where I finished in 1994 with a fellowship in otology with a Dr. Michael Glasscock, who was a fairly well-renowned ear surgeon, so I consider myself very fortunate. Since then, I've had practice in Boca Raton, and I have no disclosures or conflicts of interest that I feel impinge at all in this presentation. We have objectives that we would like to complete in this talk, and at the end of this course, I think you will find that you have learned a little bit about the ear, hopefully feel a little more comfortable in parts of the ear, and very hopefully a little less comfortable in other parts of the ear evaluation. And that's not meant to mean that you won't be learning, but you'll be learning how difficult some of the diagnoses might be and how you need to think your way through the ear and the presenting complaints and try to remember the concepts that I'm presenting, because they will help you in getting through many of the dilemmas, and try to shed yourself of some of the preconceived notions of what is a common ear problem and what is not a common ear problem, because in many cases I feel that those two are reversed. So just some very brief introductions to what hopefully most of you know already in the basic anatomy of the ear. The ear is obviously made of an external auricle. Then the term the external auditory canal represents two parts of the ear, the soft portion or the cartilaginous portion of the ear canal. And that is the portion that produces cerumen. It's also the portion that grows hair. So once you see loss of the hair, you know you've transferred from the outer cartilaginous portion of the ear canal into the bony part of the ear canal, which should be hair-free. And unless the patient is using Q-tips, should also be cerumen-free in most cases, because the cerumen glands are not in the medial part of the auditory canal. You then come to the tympanic membrane, which we will discuss in a lot more detail shortly. The ossicular mechanisms, including the malleus, the incus, and the stapes. This is a transduction mechanism where the change in surface area of the tympanic membrane compared to the oval window, which is much smaller, allows the transfer of acoustic energy of one density into a density that's greater, because the cochlea, which is the deepest structure of the true ear, is fluid filled normally. And so we need to go from the vibrations of air to the vibrations of fluid. And because of the different physical parameters, we need to have the advantage of surface area reduction, where the tympanic membrane is much larger than the oval window niche. And there's also some lever action based on the length of the ossicular mechanism that helps in transferring acoustic energy from air to a liquid in the cochlea. And then finally, the deepest part of the ear that we will consider relative to this lecture is the vestibular nerve and the cochlear nerves. And you can see, and this is fairly accurately drawn, that the vestibular nerve is above the cochlear nerve and separate from it, and it represents the two different distinct parts of the inner ear. The pars superior, or the balanced part, or the labyrinthine part, and the pars inferior, or the cochlear part. And these come from related but different structures in evolution and embryogenesis. The physiology of pars inferior, or the cochlea, very briefly summarized in this slide, shows again that there is a lever action as well as a ratio of surface areas. Not very accurate in this drawing, but it's approximately 20:1, the surface area of the tympanic membrane to the surface area of the stapes foot plate. And that gives us enough advantage to set in motion the much denser perilymph and endolymph of the cochlea. And it's this movement and differing areas of resonance that occur based on the frequency of the sound, where very high-pitched short wavelengths impinge early and longer wavelengths further down. And this is how a very significant means of distinguishing tones in a sound and encoding it into a way that the auditory cortex can understand. So getting down to some of the basics of ear examination. I feel that a very significant change has occurred in the last few years, and it may change it does change my recommendations on how you should be performing ear examinations. I think the standard otoscope has severe limitations, has never been a very good tool, and despite hundreds of years of use, its day is probably past. And although I don't have a photo, I feel that the digital wireless otoscope, as sold on Amazon for about $30 to $40, will serve you very well. And I would recommend everybody purchase one of these devices. It's easy to use. It will wirelessly connect to your iPhone or an iPad and allow importation of images directly into an electronic medical record. I also find that by placing an endoscope into the ear canal often gives perspectives that you don't get with the old-fashioned otoscope. That doesn't mean that you can get away from using the otoscope. They're present in nearly every examination room. The pneumotoscopy, which involves puffing air at the tympanic membrane, can be done only with this device. I find pneumotoscopy to be fairly limited in its resourcefulness and usefulness. And for this reason, I'm not going to go into any lengthy descriptions of how it's used, other than to say that if you could see the ear moving with puffs of air, the tympanic membrane moving with puffs of air, then you can be fairly confident that there's no fluid behind it. But it's very difficult to determine that when you're looking with one eye, not two eyes, and seeing a flat plane instead of a three-dimensional structure that the ear actually represents. It is, of course, very useful in determining if there's cerumen or a foreign object in the ear. So when would you perform an ear examination? Well, of course, new patients coming in for a complete physical, the ear should always be looked into. Why? Well, often there can be cerumen, narrowing, issues that may or may not have been determined or picked up by the patient. Many chronic ear problems are asymptomatic early on. Some of the more serious issues like perforations, chronic fluid, and cholesteatomas, other than a drop in hearing, have very few other symptoms, which puzzles many patients because they remember as a child perhaps having extreme pain with ear infections, but chronic ear infections and other ear conditions rarely result in pain, and therefore may go underdiagnosed or underappreciated by the patient. All right, well, we already talked at length about the otoscope, so I'll pass this slide on. Now, what I haven't talked about, and one of my favorite instruments, is the tuning fork. And I find that sometimes simple is better. And if you get competent in using the tuning fork, then you will not make the errors that many of your colleagues might make. I'm going to elaborate on these errors shortly ad nauseum, but the main purpose in using a tuning fork is trying to determine whether or not a hearing loss is sensory neural in nature or conductive in nature. And without the tuning fork, it's next to impossible to be completely certain, especially if you're using one of those old-fashioned otoscopes. Most serious omissions of diagnosis that I see in referrals to my office, bar none, is the incorrect diagnosis of ear infection when a patient truly has a sudden hearing loss. And your otoscope examination is, in most cases, confusing enough that it makes it difficult to truly determine whether or not you have a normal middle ear structures or fluid. And this vexes many otoscopists. Even myself at times will struggle, especially with a handheld otoscope, in trying to decide whether there's fluid in the middle ear, whereas the tuning forks typically make it quite easy to do this. So what is this examination, and why is it so important? Well, there are two examinations that are named, and that's the Weber and the Rene. And the Weber and the Rene tests are done with a tuning fork, typically 512 hertz. It's best to have a fairly quiet room, and you need to talk to the patient ahead of time and make sure that they understand what it is you're doing and why you're doing it. You have to activate the tuning fork. I typically will strike the tuning fork on my patella. That seems to be a good way of getting it going. There's many other tricks in how you get it to ring. And then you're going to ask first for the Weber test by placing the tuning fork on the patient's forehead, or I find even more effective, their upper incisor. And even if the patient has dentures, I think that sometimes you get better conduction of the vibration by picking a tooth over a spot in the center of their forehead, which is traditionally taught. It just couples a little bit better. And with that, you can ask, which ear do you hear it in? And if it's a conductive hearing loss, they'll hear it in the affected ear. And then so if they have, say, fluid in their middle ear, they should hear it when placed on the upper incisor or the forehead. They should hear it in the affected ear. Now, the Rene test is done just a little bit different. It's done with a tuning fork placed behind the ear on the mastoid process and then over the ear canal. And depending on which is louder, you can determine whether it's a conductive loss in that ear. So if it's louder when pressed onto the mastoid, then over the air, as in conventional hearing, you will conclude that this is a conductive hearing loss. In adults, this is quite rare. Most of the time, it's not conductive, and I will go over why that is so significant shortly. So here's just a nice summary slide. I have stopped using the terms negative and positive. I think it leads to too much confusion. Just document whether or not air is louder than bone in the Rene on the which ear you're testing, and on the Weber, whether it sounds in the midline, whether it goes to the bad ear or whether it goes to the good ear. And with that information, you have almost everything that you would have when it comes to making a preliminary diagnosis as to what type of hearing loss the patient is complaining of. Of course, this should be documented more fully with an audiogram. And that can wait, though, until treatment is, after treatment has begun, so that treatment, which in some cases is imperative to be done very quickly in case of sudden hearing loss, in an attempt to preserve and restore hearing, which if you don't get to it quickly with high doses of oral steroids, you're unlikely to make much difference for that patient. Very briefly, the landmarks of the ear are highlighted here. I'm not going to go into detail other than to say if you do have lesions, document them either with a drawing or with a photograph in the chart. It certainly helps going down the road to see if, say, a skin lesion or some other abnormality is changing and is concerning, to have a photograph. And today, there's really no excuse for not having photographs and charts. Basic congenital grading scale for outer ear congenital abnormalities. We have microtia, and these are grades 1 through 4, where 1 is just a small ear with basic structures present. Grades 2 and 3, where the structures are becoming significantly more abnormal, and grade 4, where they're essentially absent. And then we have acquired issues, and these two images show a cellulitis here where the entire pinna is involved, and a chondritis where the fatty portion is spared. So, and there's a different induration and level of swelling and loss of the normal landmarks in both of these, but the chondritis is somewhat more ominous in that you can get permanent changes in the ear canal if it's not drained and treated promptly. So when you do look in the ear, and here we have a lovely photograph taken with one of those endoscopes, it gives you such a nice picture. You see a normal ear canal, you see a translucent tympanic membrane that shows landmarks very beautifully. You have this dark area here, which is the round window of the cochlea. You can see an outline of the incus right here, this light area. You see a hair on the tympanic membrane, a hair in the ear canal, cerumen in the ear canal. You also see the malleus. This area is known as the umbo. You see that very commonly referred to light reflex, which I don't find that useful. It's not a real anatomical structure. It's just the light of your instrument reflecting back at you. And I think it's more important to try to identify these structures that I just mentioned. If you can see them, you can almost certainly be sure that there's no fluid in the middle ear. If there's chronic swelling, then you may have a dull tympanic membrane, still with no fluid in there, but these landmarks may be difficult to see. Or a middle ear full of fluid can also, of course, hide these landmarks. And that's where using your tuning forks is very, very helpful. If you do not see this landmark so beautifully, then the tuning fork will help you sort out the type of hearing loss, and I encourage that you to work on that skill. The leading cause of pain in the ear when you have a normal exam is the temporomandibular joint. So be thinking about that if you have a normal ear canal examination and a complaint of significant pain. Now I'm going to shift a little bit into pathology. Here are examples of different types of outer ear infection. Very common, this swimmer's ear presentation. There's erythema, there's wet wax. That's what this is. There's swelling, edema, and exquisite pain palpation. This ear, though, will clean up and respond promptly to topical drops, almost anything. Sometimes just cleaning it and drying it is adequate, although this ear probably would not be adequate. Polymyxin, neosporin, neomycin drops with some hydrocortisone are very common. But be careful and be certain that there's no perforation, because neomycin is ototoxic and is really not indicated if there's a perforation, because it has been shown to result in hearing loss in cases where a perforation is present. Here is a more typical of Q-tip use, an ear infection where there's even evidence of some cotton here. Excoriated skin could also be from a fingernail. You see other areas in the skin near the ear that's also involved with either acne or other scratch type lesions. And this is almost universally going to be staph. And I will treat this with mupirocin ointment. Fungal issues sometimes will clear up with just cleaning the ear. So if you're competent and skilled in removing this under a surgical microscope is how I would do it. You can try this. Over-the-counter Lotrimin can be effective, although sometimes it stings. My favorite way of treating this is with a compounded drop that contains Cipro, ketoconazole, and dexamethasone. We call it Ciproketodex. It's only available as a compounded pharmacy. And if somebody's interested in knowing more details on how to get that, contact me. There are numerous pharmacies in South Florida that can supply that, including Skip's Pharmacy and Specialty Care Pharmacy, the two that I use. But I've worked with them to set that up, so you may need to look it up. But there is a compounding pharmacy pharmacopoeia book where I believe it's listed, Ciproketodex. Now, there's other ear things that may look very serious, but really aren't. I commonly get consults from some of the big box hearing aid stores like Costco, and I'm asked or told to evaluate the ear tumor or the ear mass, and they are very sensitive, I think, to any kind of abnormality, and so they quickly send things out. I see a lot of it, but this is very classic osteoma. It's pearly white and it's rounded. It has a short stalk. I would reach in there and gently touch this. Sorry, keeps jumping on me. Touch this lesion to be certain that it feels hard like bone and not some soft cyst. But if you can't or don't feel comfortable touching this, this appearance can hardly be anything else. These are also osteomas. They formed a little bit differently and they represent different suture lines, but they occur along suture lines of the 4 different bones that come together to form the ear canal. Here are some other common issues within the ear canal. Here we just see some cerumen scattered around, a fairly normal looking ear. Here we can see some of the landmarks. That looks like the oval window right there. This is probably the malleus. Here we see foreign material. This is cotton within the ear canal, acute infection of the ear canal with pus. So this ear I would culture. I find that ear cultures can be quite helpful. This looks like a terrible infection, but it really just represents wax combined with shower water or swimming. And here's an example of a swimmer's ear where it has become infected and the ear canal has become swollen shut. Foreign material in the ear canal may or may not be simple to remove. This insect is obviously loose, and if you have the right tools, could be removed. But be aware that the tympanic membrane is right there behind it, and that object isn't really causing any trouble at the moment. It's dead. And if you have any hesitation at all, just leave it. It's better left, and then refer to somebody who has a little alligator instrument to reach in there and gently lift it out. This center lesion, a bead in the ear canal, can be extremely difficult to remove. There are special suctions that, if you have access to them with a little plastic cone on the tip, you might make an effort to pull that out. But I've seen more than one case of medical malpractice and litigation stem from beads in ear, where the bead, the attempt at removal resulted in instead it becoming impacted more deeply and perforating the eardrum, and in one particular case, even resulting in a facial paralysis and permanent hearing loss. So foreign bodies are not easy to remove. I've at times had to result in not just general anesthesia, but even incisions behind the ear in order to get certain objects out. So be very, very careful. I already discussed the landmarks, but this is a nice slide. It shows a right ear and a left ear and how the orientations are, and you can see the structures. The posterior superior quadrant is the most important one to look at if you're trying to see structures. This is where you can see through the drum and see the incus, which is right here. In this case, there's a little bit of difficulty seeing the oval and the round window right below the oval window. So the stapes is the oval window and below it is the round window. I really don't see it in this ear. And then the eustachian tube is in the anterior, far anterior, and it represents this darker area in this left ear. In the right ear, it's this darker area. Here's the malleus, the umbo, the light reflex, and the oval window and the round window not well shown due to angulation here. The angle of the scope is just not quite visible, and there will be a lot of variability from ear to ear. Pars flaccida is the part up above the malleus, and it's a thinner part of the ear and represents a danger area for formation of cholesteatoma. So when you look it in the ear, always look up. If you look up towards the top, often you'll find pathology that if you didn't think of looking, will get past you. And I've seen many cholesteatomas get missed because people didn't look up. I'm just going to pause for one moment here. I'm running short on time, so I will have to move along here. These are examples of simple perforations. They're dry. They can be of various sizes. This is examples of erythema, the tympanic membrane, fluid of the middle of the ear. Here's normal again. Here are different levels of inflammation, representing different levels of fluid. But say A and B may look fairly similar, except for the erythema present. So you have to be very careful in documenting. Cholesteatoma is an important thing not to miss. This represents erosion of the incus, which is the earliest form of a cholesteatoma. This white mass behind an intact tympanic membrane. This is anterior because here is the posterior superior quadrant. You know that this is a right ear because here is the incus, the stapes, and this is likely a congenital cholesteatoma in a child because it's behind an intact membrane. And in this location, cholesteatomas often occur with perforations and in association with tubes and chronic fluid, as in C here. Eustachian tube dysfunction is a common problem. People complaining of fullness and pressure, especially when flying. It can result in infections and cholesteatomas. The key point that I want to make here is that use tuning forks. You need to be able to identify, in most cases, sudden hearing loss, which is common in adults, and fluid otitis media is very uncommon in adults. And treatment of sudden hearing losses with steroids, not antibiotics. I invariably will get maybe 1 or 2 patients a week where this error has been made. They've been treated with antibiotics, they never had an infection, and they had sudden hearing loss. And that's one of the really treatable conditions that, if not recognized quickly, can lead to permanent loss. So if there's any confusion at all, especially when it comes to a complaint of sudden hearing loss or change in hearing, I think a referral to an otolaryngologist for a hearing test and examination is essential. That will keep you and the patient happy, and we're here to help. Certainly, if there's any concern, treat with steroids first. If the patient doesn't have a high fever or any obvious infection, then antibiotics often can wait. And in Europe, most otitis media is treated with steroids and not antibiotics, so you're treating both. With that, I thank you. Any questions, feel free to reach out, and hopefully we will see you at the live meeting.
Good morning. It's an honor to be here today and to discuss one of the more challenging topics in general otolaryngology. My name is John T. Lanza. I am a general otolaryngologist in St. Lucie County. I've been in practice approximately 25 years actually, in a general otolaryngology setting. I'm going to take you through my experience with dealing with head and neck tumors over the next 20 minutes or so. I'm going to keep the presentation quite basic, and it is geared towards advanced practitioners, specifically ARNPs and PAs. So let's begin. Head and neck cancer, and what I'd like to call this presentation is what you need to know for the front line, is primarily centered around squamous cell carcinoma. The incidence of head and neck cancers is a little ambiguous. Some reports say it's in the arena of around 80,000 a year. Some report 200,000 a year. But for our sake, it's anywhere greater than 100,000, which means it is quite plentiful in most general ENT practices in the state of Florida. In our practice, the leading etiology is viral, primarily for the base of tongue and tonsil, and that's the tumors we're seeing most commonly. When you think of risk factors, historically we think of head and neck cancer being due to or attributed to a history of smoking and or chewing tobacco with the addition of alcohol. However, viral contributors, specifically human papillomavirus, is actually becoming the predominant cause of the cancers that we're seeing in the head and neck in our area, with the exception of those in the larynx. Larynx, it still seems to be most likely consistent with a history of tobacco use. However, just for the sake of completion, there are other contributors or causative factors that need to be thought about. And folks from the Indian continent, there is a known use of betel quid, which they chew, and that's been associated with oral cavity cancers, buccal mucosa, gingiva, and lingual tongue. Then there is industrial exposures linked with squamous cell carcinomas of the sinonasal tract. And lastly, folks of Asian heritage have an association with nasopharyngeal carcinoma. In today's lecture, we're going to concentrate primarily on the oral cavity, that is, starting with the lips, buccal mucosa, palate, soft and hard, lingual tongue, floor of mouth, gingival ridge. Oral pharynx will include the tonsils, posterior fold, the posterior pharyngeal wall, the nasal cavity and sinuses, the nasopharynx, the hypopharynx, the base of tongue, which is now becoming a high prevalence site for cancers in our practice, larynx, cervical esophagus, and proximal trachea. When you're examining your patients, you got to do your best to not just inspect what is easily accessible. You need to look at the base of tongue, and for those of you trained in flexible or rigid endoscopy, the hypopharynx, larynx. Don't forget to palpate. Put on gloves. You should get used to palpating the tongue and even the tonsillar area. Soft palate, retromolar region, in the gingival-buccal groove, in the gingival-lingual groove. Feel the floor of the mouth. Understand what are normal variations so that when you do come across something, you'll appreciate the fact that it doesn't belong there. Next slide is, we're going to limit our discussion to those sites, and we're going to be aware of other tumors that occur in the head and neck. However, we're not going to include those in today's discussion. Each of these sites would require their own lecture, specifically salivary glands, benign and malignant parotid, submandibular, and the rare sublingual tumors, diffuse lymphadenopathy, primarily those that are associated with lymphomas, thyroid disease, both benign, malignant, and goitrous changes, metastatic lesions to the head and neck. In the supraclavicular area, you can see breast, you can see lung, you can even see occasional prostate. So you have to keep those in your differential. It's not the kind of thing that we need to get into great detail today. As I said, each of these topics can have their own lecture. Cutaneous tumors, when you're evaluating your patients with a high neck node, make sure you do inspect the scalp. Many times there could be an underlying melanoma or squamous cell carcinoma in the scalp area. Parotid tumors are predominantly benign, and they're quite common in our practice. Thyroid nodules as well, but again, we will not be addressing them in detail in today's lecture. So for head and neck cancers, what do you really need to know for the front line? You have to be attentive to changes in appearance of mucosa, any wet, white, red, or dark lesion in the mouth. Be suspicious about it. Ill-fitting dentures. Patients will come in and they're carrying their dentures or their partials, and I can't get them to fit, and that could be a first indication of that's where you need to look for an underlying tumor. Unilateral nasal obstruction could be the presenting sign for a sinonasal cancer. Deviation of the tongue, paralysis of the innervation to the hemitongue resulting in deviation means that you really need to start palpating the tongue. Put on a pair of gloves, feel the tongue, be suspicious of the tongue base. And of course, any mass or swelling throughout the face, head, and neck, you have to be suspicious for head and neck cancer. So essentially, be observant and be diligent in your exam. Head and neck cancers, their presentation and their symptoms include not only the lump in the neck, not only a sore that doesn't heal, but it can also include ear pain, a unilateral ear effusion, trouble swallowing, throat pain, voice change, sense that they have a foreign body in their throat and they can't clear it. This other presentation can include a relentless cough with or without hemoptysis. So make sure you do a bimanual palpation on the neck and areas of concern. Inquire about hearing issues. Inquire about voice change. Is this your normal voice? So always be suspicious. The take-home message is be suspicious always. When the pieces of the history and the exam just don't fit, do not blow it off. Do not say, okay, I'm going to create, you have an infection, and I'm going to give you an antibiotic, and discharge that patient after 10 days of antibiotics, and therefore they're going to feel like, okay, there's nothing really wrong here. The antibiotic gets them partially to feel better, and then they just ignore their symptom for a few more weeks. Always bring back the suspicious patient in 3 to 4 weeks. Explain to them that on today's visit you don't appreciate anything to be worried about, but that you share their concern for their well-being and that you would like to see them at least a second time for another look. So the next few slides include clinical pictures. You're looking at a 72-year-old female with a non-healing ulcer in the right mandibular gingivolingual groove. You could see that there was an ulceration that's right in the gingiva surrounding their dental implants. They thought they were just dealing with an infection. They sat on it a little bit. They finally went to their dentist, and then the dentist eventually did a biopsy, which came back invasive squamous cell carcinoma, and then asked for our opinion for definitive care. This unfortunate next lady is an example of someone who developed a neck mass and ignored it, and then developed a second neck mass and finally came in for evaluation. She's a 73-year-old lady with multiple neck masses of the right neck. You can see there's a visible scar in the skin. She had local skin cancer resection by a dermatologist, and then decided that, she just wasn't going to get evaluated at the point of one mass. She needed for the second one to occur. Both of these are metastatic squamous cell carcinoma, but not of the overlying skin cancer. She has a right hypopharynx, base of tongue tumor, in addition to what you see on the neck. This is another example of a 66-year-old male who came to the office complaining of tongue pain. And on examination, you notice there's an ulceration in the left lingual tongue lateral edge, adjacent to the molars. And the patient says, "Oh yeah, I thought I bit my tongue." And then you feel it, and when you feel it, it's more than just an ulceration from tongue trauma. Essentially, there is some tongue trauma, but he was biting the tumor that was in the left lateral tongue. The tongue pain was present for approximately 8 weeks. So the next slide is a voice change in a 70-year-old male presented for evaluation of intermittent trouble with voice, which then became a persistent voice change. And you're looking at a papillomatous type of tumor sitting on and replacing the right true vocal cord up to the anterior commissure, and it has already begun to cross over and is now involving the left anterior 1/3 true vocal cord. This is somebody who first noticed foreign body sensation in their throat, and then progressively worsening voice change. Next slide is a 54-year-old county employee, worked outdoors, was in the sun all day, involved with road repair. He wore a handkerchief over his face, and presented into about the 3rd or 4th month of the COVID pandemic. And no one even knew that he had the problem because of the face mask that he was wearing. Fortunately, we were able to resect this in conjunction with our plastic surgery colleagues who did an actually beautiful Abby Estlander flap on the repair. We were able to get clear margins. The tumor went down and did involve the submental nerve on that side. We ended up with a significant defect, but the reconstruction was actually marvelous. This is a 67-year-old male who complained of tongue swelling. Tongue swelling was present for about 3 months before he finally came in. Next is a 78-year-old female who thought her change in speech was attributed to her history of TIAs and CVAs, and as it turns out, she had a rock hard mass in the base of tongue. This is a 58-year-old male who thought he had some bad allergies until he developed daily nosebleeds for 3 straight weeks. That's when he came in to have us take a look. And again, the take-home message is be suspicious always. You would like to biopsy areas if possible, as early as possible, and you have to think about your imaging options. In my practice, it's primarily ultrasound of soft tissue neck and CT with contrast to the neck. Typically, if a patient presents with a single neck mass and no identifiable mucosal disease, I'll consider an ultrasound of the neck mass to get a better understanding from my radiology colleagues of what I'm really looking at. Am I looking at something that's cystic, solid, what it's adjacent to, if it's a lymph node, what are the ultrasound changes within the lymph node that are either more suspicious for malignancy. And then if there is suspicion and no definitive mass can be appreciated, and yet you're dealing with a high-risk individual, a CT scan with contrast. Getting that baseline CT is very, very helpful, especially if you're dealing with a tumor that you can't palpate, something in the hypopharynx, something beyond your grasp of the tongue base, or even the larynx. So the dilemma really starts with once you get that information and you're presenting the news to your patient. Remember, making the diagnosis is just the beginning of the journey that this patient's about to start. Now, if your initial workup is negative, meaning CT scan does not detect, the ultrasound looks totally benign, remain suspicious. If it's positive and you need to give someone bad news, remember it's still okay to hold someone's hand or give them a hug, and it is appropriate to embrace them still, despite what we're being told with COVID. And you're helping to guide them through the process of managing their new diagnosis. Fortunately, most cases are successfully managed long term, and the patient needs to know that you are on their team and that the prognosis is not dismal, although their journey will be very challenging. Things that you want to give them to control and have a sense of control are encouraging them to maintain good nutrition, maintain good oral hygiene, help them remain in control of their own bodies to the greatest extent possible. And just a brief talk about the appropriate options of definitive care. We'll use typically some combination of surgery, external beam radiation, chemo, and now biologics, and in certain circumstances, vaccines. So before anyone heads to the exit, and for those of you at home, I know that's a little bizarre, but I always want to make myself open for questions. And if there's any questions that are in the audience, I'm happy to answer them. I will be available live on site in Naples on the program on the day of the lecture that's being scheduled. So again, thank you very much for the opportunity. I appreciate you taking the time to participate in this lecture on head and neck cancers. What do you need to know for the front line? A primer for ARNPs and PAs. Thank you.
Welcome to this recorded session. The presentation you're about to hear is titled Current Paradigms in the Treatment of Head and Neck Cancer. Two of us put this presentation together. My name is Matthew Mifsud. I am an assistant professor of otolaryngology at the University of South Florida, and I work with our head and neck oncology and microvascular team. And with me, I have Hock Dang, who's a PA who's worked with us, quite frankly, for longer than I've been a resident, and her main focus has been head and neck cancer. So hopefully we'll have a good amount of experience from different sides today. And we have no relevant disclosures. So I always start with this basic story. It's one I tell our residents a lot about. It's a 70-year-old gentleman who came in after about a year delay of facial paralysis, eventually found to have a cancer of his parotid gland. And he had a really extensive treatment, parotidectomy, radiation, the works. Unfortunately, about 2 years after that, he died from metastatic disease. I tell him about this case because it's my uncle, and I think it also says a lot about head and neck cancer. And you can see he went from being a really vibrant guy, used to play soccer in college, to really being eaten away by his cancer. And I think our head and neck cancer patients have a lot of challenges. It's a very rare group of cancers, are often misunderstood. A lot of radiation oncologists and medical oncologists really don't have a lot of good experience. And the other problem with these cancers is that many of our patients have lifelong challenges. They can't swallow, they can't work, they have changes in speech, and many have disfigured. The other problem, I think, with head and neck cancers is that there's not one type of cancer. You know, lung cancers are very algorithmic. Breast cancer, there's different entities, but it's breast cancer. For head and neck, it's really a group of many different cancers, but they all happen in one region. And I think this variability is very confusing. It's confusing to physicians and surgeons, confusing to patients, confusing to all of this. And I think if you want to break it down, I think the natural history, the anatomy, the pathology, all of that is really how we decide to treat these and to stage these. And when we think about head and neck cancers, this is sort of an amalgamation of what's out there. You have your mouth and oral cancers, the nose and sinus, larynx, skin cancer, salivary, and then others. And this is sort of a breakdown of that. And today, I think we're mostly going to focus on the traditional air digestive tract cancers, with the exception of oropharynx. I know Dr. Magnuson should hopefully shortly be giving a talk on transoral robotic therapy and oropharynx cancer, so I didn't focus too much on that to avoid redundancy. And kind of looking at paradigms in treatment of head and neck cancer, this is really what we have. There's surgery, there's radiation, there's chemotherapy and immunotherapy. When we look at chemotherapy and immunotherapy, for the most part, these are things that are supportive of surgery and radiation. And with everything changing in immunotherapy, this really hasn't changed. So the bulk of our talk today is really going to be talking about surgery and radiation, because really chemo and even immunotherapy, even though they're hot topics, they're really only still supportive topics in day-to-day practice. So the objectives that I kind of have listed here, first is to learn how to effectively stage these cancers, and we're kind of pinpoint some of the key focuses here. I put a little bit about the unknown primary, what to do about the neck mass, the neck node, how to manage that. We'll talk a little bit about when primary and adjuvant radiation are appropriate, and there'll again be some case vignettes about that. And then finally, we'll look at appropriate post-op treatment. So Hock's going to take us through basics of staging.
Good afternoon, everyone. Thank you for having myself and Dr. Mifsud present at this meeting. General head and neck staging is, I group everything together as in this slide that you can see here. T1 is usually a tumor that we cannot find out where it is. TIS is something that is very small, very superficial. A T1 tumor is usually less than 2 centimeters in size. T2 tumor is between 2 and 4, but no greater than 4. And then a T3 tumor is greater than 4 centimeter. And then the most advanced, we're looking at what we stage as a T4, which is moderately advanced and invading adjacent structures. Some pretty basic nodal staging in head and neck cancer. NX means that clinically we cannot assess whether the patient has lymph nodes or not. This would be revealed when we order new imaging. N0 neck is no distant disease in the head neck area. And then moving on to N1, just a single lymph node, usually less than 3 centimeters in size, contained to the lymph node itself without any extension into the surrounding tissue. N2A, another single lymph node, greater than 3, but less than 6, also without any extension into the surrounding tissue. N2B, several lymph nodes, all of which are less than 6 centimeters in size, contained to the lymph node itself. Moving to N2C, you have disease in both necks, all the lymph nodes are less than 6 centimeters, contained to the lymph nodes. And then the most aggressive neck disease are the N3s, which are greater than 6 centimeters, and the lymph node is pretty stuck to the surrounding tissue in the neck area, making it difficult to dissect.
So I think we want to talk specifically about oral cavity cancers because they're a little bit unique. And you can see, this is a picture I found and how can help me put together, that there's many different subsites of the oral cavity. Each area is a little different. So I wanted to start with this first case. This is a very young girl who came to me with what looks like a relatively small oral cavity cancer, but you can kind of see on this CAT scan, it's fairly deeply invasive and crossing the midline. She's only 19 years old. So we actually took her for a partial glossectomy and a neck dissection. I did a reconstruction with a 5 flap. And I apologize, a lot of my cases weigh heavily to free flaps, and that's just a sort of what it is in my heart, and that's what I take my best pictures of. So I apologize. I'm not trying to advocate that everyone needs a free flap, but it's where my sort of best cases are. But when we look at the path here, we can see it's a mid-sized cancer, 2.9 centimeters. A big key here is that it's a very deeply invasive cancer, 15 millimeters in depth. And despite the fact the CAT scan was negative in the neck, she did have 1 lymph node that was positive. And we staged her as a T3N1, so it actually would be a stage 4 cancer based on our staging. And she went through radiation and is now recovering. You can see this is her with her free flap. And one key thing about her surgery is functionally, even 1 month out, she was doing quite well. And if this will play. What are you eating? I'm eating rice. I started eating you can see, she has a little bit of a slurred speech and she's got some challenges ahead of her. She's doing better now. But even a month out with the right surgery, the right healing, we can get them functioning pretty well. Hawk, do you want to talk a little bit about depth of invasion?
Yes. Depth of invasion has become a pretty important parameter to a very important predictive parameter in the aggression of head and neck cancer. With the introduction of the AJCC 8th edition of head and neck cancer staging, they've introduced the role of the depth of invasion, which is abbreviation is DOI. So DOI is now used in conjunction with tumor size because head and neck is more of a surgical specialty. Most of our cancers in the oral cavity will require surgery. So we have a more robust pathological and staging information. So the patient is staged either, first of all, clinically based on exam and the greatest dimension of the tumor on exam in the office. After surgery, after the tissue is obtained, we can get a better pathological staging of the tumor, incorporating the size of the tumor plus the depth of invasion of the tumor. Now, depth of invasion is not describing tumor thickness as most people may think it is, but it actually measures the level of the basement membrane of the closest adjacent normal mucosa. So with the advent of the depth of invasion, we are looking at cancers that can be increased in tumor size. For example, without depth of invasion into consideration. A tumor that's initially at stages of T1, such as less than 2 centimeters in size, clinically with the judgment that it is less than 5 millimeters in size in depth invasion, we would stage it as a T1. However, after surgery, once the tumor is removed, even though the tumor is less than 2 centimeters in size, based on pathology and histology exam, if the tumor depth of invasion is greater than 5 centimeters, and even though it's a tumor that's less than 2 centimeters, is now staged as a T2, and so forth.
Yeah, I think the real important part about that staging is that once you have a depth of invasion greater than 5 millimeters, the risk of lymph node metastasis is pretty high. And if you don't treat that neck, you end up in trouble. It's something that really is important, and we often see recurrences because that's not been addressed. I think, Hawk, you had mentioned a nice slide here about mandibular involvement. And I think the key with all this is that when you have a cancer that's kind of sitting or abutting the mandible, that has to be treated, and that when we do have these mandibular cancers, their risk of recurrence is much higher. You want to talk a little bit about different treatment options for that, Hawk?
Yes. So with mandibular cancer, let me see.
I think I flipped the slide on you there.
Yeah. So there are different, when we're talking about mandibular cancer, we're looking at different regions in the oral cavity. There are 4 subsites that we need to consider. One of them is the mandibular alveolar ridge. Number 2, the lower buccal sulcus. Number 3, sublingual sulcus. And number 4 is the mandibular retromolar trigone area.
And what we were kind of showing in this slide is that if that mandible is involved, if there's not this layer of healthy tissue between the cancer and the bone, you need to really address that. And I've seen a few patients where they kind of do a partial surgery and they leave some cancer behind, they try to radiate, and the problem is these patients just don't heal very well. And even if the cancer goes away, they get osteonecrosis. So this is an interesting case. And again, when you look at this through the mouth, it looks more like a tongue cancer than a mandible cancer. But when you look at the imaging, particularly the sagittal imaging, you can see that the cancer is very clearly abutting the bone. And as Hawk kind of pointed out in her slides here, if there's not a clear plane here, you're going to have to do something with the mandible. In this case, we chose to do a marginal mandibulectomy and actually preserve most of the mandible. So you can see he had a marginal mandibulectomy, he lost a bunch of his tongue. We didn't just primarily close this, we put again another free flap in. And he actually had 2 nodes that were positive. He had a pretty advanced cancer, but luckily that bone in itself wasn't involved, but we took that bone out to clear the margin. And I tried to send him for radiation, again, because he had lymph nodes and high-risk features, but he was kind of a crusty old guy and got through a bunch of treatments and just bailed out. Next case I want to give is about our unknown primaries. This was a healthy female, 3 months of a left neck mass, 6 years old. She's gone through multiple courses of antibiotics and all this without change. And you can see what looks like a fairly benign looking cystic lymph node. The problem is in adults, most of these are going to be cancers. And I think you really have to think in your head, what are you going to do to prove that without misdiagnosing them? And these are sort of the steps I think of. Look for the primary if you can find it, select the right imaging, and then either refer them out or treat them appropriately. So, the primary is, again, you're really doing a really comprehensive exam to look for something. You want to make sure you scope them. You want to look at the nasopharynx. You want to look at the piriforms. If you have to, take them to the operating room for a direct laryngoscopy. You want to try to find a primary if one's there. And you want to think about some suspicious findings, things that, maybe aren't as obvious as that picture I showed before, the asymmetry of the tonsil, firmness if you get along the back of the tongue, any asymmetry of movement of the palate. If you've got, obstructive masses or a unilateral fusion, these things really have to make you think of cancer. Imaging is important. I use a lot of ultrasound in my clinic because I do a lot of my own ultrasound. However, it's very opera dependent. I rarely will send anyone for radiology guided ultrasound because I just don't think you get a very good answer. So that really leaves you with CAT scan or MRI as your primary treatment. I like CAT scan a lot. It's relatively short to do. It's a lot less expensive than MRI is. It's better with mental or general artifact. And for the nodal disease, I think it gives you the best bang for your buck. MRI, on the other hand, is probably a better study, gives you much better soft tissue definition, and it's really good for skull-based tumors, cranial nerves, in theory for a tongue tumor to define the actual extent of tumor. However, it's much more expensive. Patients don't like it because it takes a long time. It's often hard to get a really good image, especially on my computer screen, and it's a lot more issues with implantable devices. So I use MRIs more judiciously than CAT scans, which is why all you're going to see in this presentation are CAT scans. And then PET scan, I think, for neck nodes is really important. It's really good at showing primary lesions under the surface. And oftentimes, if you have a neck node that you can biopsy with a fine needle aspiration and then a good PET scan, that on its own can almost define your treatment. The biggest problem I have with PET in our practice is sometimes insurance just won't cover them. So something you got to work with. Fine needle aspiration is great, high degree of accuracy, great safety profile, and often can expedite care. The one hesitation with some of these cystic lymph nodes is from time to time, you just can't get a good sample. So in this patient, that's sort of what happened. We didn't have a good FNA, but I kind of knew that they were cancer. And I also knew this was cancer that we probably could treat surgically. So we started out with a neck dissection. I didn't just pluck the node out, but we did do a formal neck dissection. We staged the tumor. We found out that it was in fact HPV positive oropharynx cancer. You could then debate about the different treatments, but she went on to have a transoral surgery to the primary site, which is sort of like a basic tongue primary, and she was treated with surgery alone. The last thing we really want to talk a lot about is larynx cancer, and you can see there's multiple subsites. And I think, Hawk, the one thing in this slide I think we should point out was that T3, T4, if you kind of touch base on that.
Yes. So larynx cancer is very tricky. We have to start with a very thorough flexible fiber optic exam in the office. Sometimes you can see an obvious tumor in the larynx, sometimes you can't. In that case, either way, you would need to take the patient into the operating room for a comprehensive exam, which will involve a pen endoscopy with superficial and deep biopsies. So T1 tumors are very small tumors, very superficial. T2 are a mid-sized tumor with significant depth of invasion. The T3s are the most involved in the sense that the vocal cord is now paralyzed, the patient is hoarse. There's some invasion into the paraglottic area and pre-epiglottic space, and oftentimes the thyroid cartilage is either involved or destroyed. And a T4 larynx cancer has grown outside of the voice box and is grown through the thyroid cartilage and surrounding areas such as the thyroid gland, oftentimes the trachea, esophagus, and even the upper tongue and neck muscles.
And I kind of put this as a basic outline for larynx cancer treatments. And I would say for T1, a true glottic cancer or small primary, pretty much anything you do is going to have a high success rate. And that could be transoral laser section, radiotherapy. For the T2 to T3 tumor, for the most part, it's actually going to be chemoradiotherapy. There are some types of laryngeal surgeries. There is some transoral surgery you can do for these cases, but usually those are very selective groups. And for the most part, you're looking at chemoradiotherapy, except for very large T3s. And then for T4, for the most part, if it's destroying the voice box, you really need to do surgery, and usually that's going to be an upfront laryngectomy followed by radiation. And this is a case I wanted to illustrate I thought was interesting. 57-year-old guy. He was initially staged outside the T1A, but he came to see me and I was looking at him in the clinic, and he really had some subglottic extension. So it was really more of a larger T2 tumor. And you can kind of see that in this PET scan. It's creeping below the vocal cords. And he was treated with radiotherapy. You could argue for any chemo, but that's a separate discussion. So he initially did really well. I saw him about a month post-op. He was doing great. But now he's starting to get this stridor. His vocal cords aren't as mobile, a lot of swelling. So the question is this a treatment-related impact or is this cancer? And it could be either. Unfortunately, this gentleman is really averse to getting treatment. He really needs a trach. He's actually moving to Houston, so I don't really have an answer to it. But it really brings up something that Hawk really wanted to push forward here, which was this idea of functional larynx. And it's not just about curing cancer, it's also preserving function. And you can kind of see what we put here is that all these different functions that the larynx has. And these are some of the adverse impacts that radiation can have. And I don't know if Hawk, you want to kind of go through this briefly.
Yes. Patients will often have what we describe as stridor, meaning more inspiratory stridor because of all the swelling in the voice box after radiation. They also have a tendency to complain at almost every visit about severe throat pain, which is very difficult to treat. They also have very difficulty in swallowing, even thin liquids such as water, some neurotoxic reactions such as chronic pain in this area. And most importantly, their airway can be very narrow due to chronic swelling, fibrosis of the intrinsic laryngeal muscle, causing the vocal cords to be very stiff. And this can also lead to a compromise in their airway.
And, you know, when we think about how to treat this, there are some patients that even if they've been cured from cancer that still need an operation. And it's also one reason to really select who you do treat with chemoradiation. And that's because you can't really survive with the non-functional larynx. You're often G-tube dependent and you often have a trach. As Hawk kind of pointed out on this slide, some of them even have recurring aspiration pneumonias. So many of these patients really do benefit from a laryngectomy, and frankly, their function when it comes to swallowing and even speech with some of the prosthetics we have and electrolarynxes we have really can be better than they were before. I had a case of a high-risk skin cancer. I think for time, we're going to move on for that one. And if we're lucky, I'll be able to present this live at the actual conference. So this is a slide that looks at post-treatment surveillance. And these are all cases I did in my first year of practice, who I now took pictures of over the last year, almost about 4 years later. I think it's really key that once you treat head and neck cancer patient, they're yours. And the surveillance is really important. Hawk, did you want to talk about supportive care a little bit?
Mm-hmm. Like Matt said, these patients become yours forever and ever. They always complain about the same things. And so I'm just going to go over some of the things, the more common things that they tend to complain about. Number one, they complain that their voice is weak or they can't swallow. So you have to consider sending them to a speech pathologist to work on improving their swallowing and work on improving their speech. Weight maintenance is also a problem due to difficulty in swallowing. So we want to make sure that they have the necessary needs to talk to a dietitian so that they can come up with a nutritional plan so that they can maintain their weight. Also related to swallowing because of scarring of the esophagus, the pharyngoesophageal area. We oftentimes at Moffitt will send these patients to endoscopy for serial dilations. Head and neck radiation chemotherapy to this area can also cause them to have eustachian tube dysfunction or decreased hearing. So we have to make sure that they get at least a baseline hearing evaluation, if not an annual hearing evaluation. Family support can be very limited in these head and neck patients. So we have to make sure that there is a social worker or a case manager that they can talk to concerning some of the medical needs, such as transportation to their visits, social needs, and emotional assessment. As you know, these patients deal with a very tough disease, and it can be very hard on them, especially when their social support is very limited, as most of our patients are. And lastly, they talk about not being able to chew because of prior surgeries, and they always want more. They always want teeth or dentures. So just make sure that they are referred to an appropriate dentist or a prosthodontist to fabricate new dentures, bridges, dental posts, or obturators to help with chewing.
And then this I thought was a good overview of some follow-up. Do you want to go over this quickly?
Mm-hmm. At their annual visit, we always like to make sure that they either get a CT of the chest for lung cancer screening, as most of these patients are former smokers. Worst case is a chest x-ray. We also make sure that their thyroid function's working, so the TSH level needs to be checked at least every yearly by us or by the primary care. CT, MRI, depends on level of concerns, how compliant the patient is as far as follow-up is with you. PET scan, typically ordered after post-treatment, usually 12 weeks. We don't order it too much unless there is a new concern or physical finding post-treatment. And lastly, ultrasound is very underutilized. As Matt said, he likes to use it. And I also like to order it very often. It's good for overall neck surveillance and to evaluate for adenopathy or very vague neck fullness that patients like to complain about.
And then I kind of broke down our follow-up algorithm. There's obviously some, this can be debated in different institutions, but I think this works well for us. I mean, for the first year or two, you really need to see these patients every 2 to 3 months. That's because the majority of recurrences for head and neck cancers happen early. So you really need to keep them close those first 2 years. In the 3-year to 4-year range, we start to spread out 4 to 6, then to 6 months, a little depending on the patient. Some people really don't want to come back and they spread them out a little more. Some people are very anxious and really want to see you more. And I think you kind of gauge that based on your concern and their concern. And then at 5 years, I think our party line is they can see us if they want, or they can kind of head off. But many of these patients, particularly those that end up with complex surgeries, will often come back once a year because they have unique needs, unique issues that just no other type of physician knows how to handle. I think the one last staying point in this presentation really has to be, if you're going to be involved in taking care of head and neck cancer patients, you have to be the ones that keep managing them pretty much for the rest of their lives. I can't tell you how many patients I've seen that refer to a radiation oncologist, had the radiation, never saw an ENT, and then come as a referral to us too late down the line with problems or recurrences. And I think as an otolaryngologist, someone working with ENTs, you really have to think, if this is a patient that you're going to take on, you need to make sure it's your job, because of all the skills that we have, to really follow these patients. So I think we'll end there. We thank you very much. And hopefully some of us will be doing this live in Naples. Bye-bye.
Thank you, everyone.